Nearly 2 per 1,000 pregnancies are complicated by pre-existing diabetes. Women with pregestational diabetes may have either type 1 or type 2 diabetes, although type 1 is a more common diagnosis. Fetal risks for type 1 and type 2 diabetes are about the same, however, maternal risks tend to be greater in women with type 1 diabetes. This is because glycemic control tends to be more difficult to manage because of absolute lack of insulin production. Type 1 diabetics are also at a higher risk of vascular, retinal, or renal complications that accompany the disease. Insulin dependency is likely with nearly all women with pregestational diabetes during pregnancy. Preconception counseling is recommended by the ADA for all women of reproductive age with diabetes for the very important reason that it is associated with improved pregnancy outcomes. Lola is a 23-year-old newly married woman. Was diagnosed with diabetes when she was 16 years of age. Her diabetes has been fairly stable for several years, although she occasionally experiences glucose control problems requiring reevaluation of her insulin dosage and diet. Lola and her husband are planning to become pregnant in about a year.
Lola, it's terrific that you and your husband are asking about the importance of preconception care and discussing your plan to become pregnant in the next year. Preconception counseling is especially important for women with pregestational diabetes so their health status can be evaluated and they can be advised of the optimal time for pregnancy.
Evidence has shown that when women with pregestational diabetes achieve optimal glycemic control before conception, they greatly help curtail the risk of birth defects among their offspring.
Lola, are you aware of some of the risks and complications associated with pregestational diabetes?
Yeah, I do know that it's important to have really good glucose control to prevent early pregnancy loss, and I think I've heard about excessive birth weight and also hypertension during pregnancy.
That's true. Larger birth weight babies may occur in up to 50% in women with pregestational diabetes with poor glycemic control. These babies have an increase in shoulder and trunk size, so there is a greater risk of shoulder dystocia. Women with diabetes also face an increased likelihood of cesarean birth or operative vaginal birth. Hypertension disorders such as preeclampsia or eclampsia is another potential complication with women with diabetes. Without proper glycemic control, you are more likely to experience preterm birth or labor and induced preterm births.
Well, I definitely don't want that to happen, so I will make sure that I maintain my blood sugar on a daily basis.
Good, and remember you are at an increased risk of infections, such as urinary tract infections.
1 year later, Lola does become pregnant. She is now 4 weeks pregnant and is about to have her first prenatal visit.
Lola, what's your understanding about your insulin regimen during pregnancy?
Well, my doctor said I should try to keep my glucose levels between 60 and 120. So I've been trying to do this, but I've been hungrier than usual. I'm trying to follow what the nurse said at the doctor's office about my diet, eating 3 meals and 1 or 2 snacks. I check my blood sugar before meals, and that doctor was definitely right about needing more insulin with this baby. Sometimes I have to give myself 2 or 3 injections, but Anthony and I are just so excited about the pregnancy that it's okay.
That's right, Lola. The need for more insulin is caused by hormones the placenta makes. The placenta makes hormones that help the baby grow. Your doctor probably mentioned that insulin is safer during pregnancy than oral medications. Lola, it's important for you to have regular visits with your doctor so that your meds can be adjusted to achieve and maintain normal blood glucose level. Normal fasting blood glucose level should fall within the range of 60 to 120. And be sure to keep your visits with your doctor so that you can achieve excellent blood glucose control and have a healthy baby.
Maintaining strict glycemic control is the primary goal of medical therapy for the pregnant woman with diabetes. The primary nursing goal is to provide education, skill, and motivation to help Lola achieve and maintain blood glucose control.
Lola, it's important for you to be on a consistent daily schedule. You can do this by going to bed, waking up, eating, exercising, and taking insulin at the same time every day. Also, it's important to wear an ID bracelet and carry your insulin, syringes, and glucose boosters with you on a daily basis. Here are some written instructions for you to read more about monitoring your glucose and reporting problems such as nausea, vomiting, and infections to your doctor right away. Here's our phone number, and don't hesitate to call. even on weekends or holidays, should you experience any of these problems.
Lola has returned for her second prenatal visit to discuss the results of her glycosylated hemoglobin test. Glycosylated hemoglobin is hemoglobin that is saturated with glucose. A diabetic patient's glycemic control can be tested by measuring the amount of glucose attached to red blood cells. Unlike a fasting or random glucose check, an HbA1c reflects glucose control over time, specifically over the previous 8 to 12 weeks.
Lola, I have the results of your HbA1c and everything looks good.
Great. What was my level?
5%. As you know, we like to see the HbA1c levels around 5 to 6%, so keep up the good work. I think it's important that we talk about diet modifications at this time.
Okay, great. I already have a strict diet regimen and was wondering what changes you could recommend now that I'm pregnant.
Diet modifications has a significant effect on the maintenance of diabetes. The goals of diet modifications with pregestational diabetes are to provide weight gain that is consistent with normal pregnancy, and also prevent ketoacidosis and minimize fluctuations in glucose levels. Since you are of normal weight and BMI, you will need to consume about 30 to 35 calories per kilogram of weight. This averages out to about 2,200 calories in the first trimester and 2,500 calories in the second and third trimesters.
Okay, is there anything I should be eating more of, like more protein?
That's a great question. Your diet should consist of 40 to 50% carbohydrates with a minimum of 250 grams per day, 20% protein, 30 to 40% fat with no more than 10% from saturated fat. Your fat intake might need to be decreased if you're gaining weight too rapidly.
I love to snack on fruit and cereal. Can I continue to do that while I'm pregnant?
Fruit and whole grain cereals can be a great snack. Your carbohydrates should be complex carbs that are high in fiber, so apples, oranges, pears, and whole grain cereals work just fine. I'm glad to hear that you're eating snacks. As you know, with diabetes, it's not only what you eat, but also when and how often you eat. Are you getting 3 meals a day with at least 2 snacks?
Yeah, sometimes 3 or 4 snacks.
Good. Make sure your meals are eaten at the same time every day and that your snacks are incorporated in accordance with insulin therapy. You should also know that eating a bedtime snack can prevent hypoglycemia and starvation ketosis at nighttime. Something like 3 graham crackers, which has about 25 grams of carbs, would be a good choice.
Lola has been experiencing increased stress as a result of the change in her diabetes associated with pregnancy. She is meeting with Nurse Jen to get advice on ways to reduce stress. Stress management is very important for pregnant women, especially those with high-risk pregnancies. Pregnant patients with pregestational diabetes need to be especially proactive about managing stress because it can have a negative impact on glucose levels.
The first step to managing stress is to identify your triggers. Lola, can you tell me about some things that are triggers for your stress?
Well, sometimes I get stressed out about money, and sometimes my husband annoys me.
And do you have any techniques to manage these things?
Sometimes I go to the gym, and I like to eat healthy, and I find that when I get more sleep, my stress is managed better.
That's all great. Those are great ways to manage your stress and keep it at bay.
Lola is now in her 3rd trimester and is discussing breastfeeding with her nurse.
Nurse Jen, I wanted to ask about breastfeeding. My concern is that it will be too hard on my body, and I won't be able to breastfeed effectively.
Lola, I understand you are concerned that being a diabetic may affect your ability to breastfeed. I'm here to assure you that breastfeeding is 100% healthy for both you and your baby. In fact, we encourage you to breastfeed because breastfeeding has an anti-diabetogenic effect. As such, blood glucose levels and insulin requirements are lower because of the carbohydrate used in milk production. Also, during lactation, you may be able to eat more food and still take less insulin. Just be cautioned that insulin dosage must be adjusted as the infant is weaned from breastfeeding.
Following a successful uncomplicated vaginal birth, Lola's primary health care provider advises her to avoid another pregnancy for at least 2 years. Lola plans to resume the use of a diaphragm as her method of contraception and discusses that with her nurse.
Nurse Jen, I want to thank you for all the prenatal information that you've given me. It's been a month since the delivery of my healthy baby, Carol. The transition was made a lot easier because my husband and I were very well educated on the topics related to my diabetes and its effects on pregnancy.
Lola, congratulations on your healthy delivery. I'm glad you found the information helpful. I'd like to touch base with you about family planning and how you will safeguard your health and promote optimal outcomes for future pregnancies. As you know, excellent glucose control at conception is crucial for all women with diabetes to ensure the health of your baby. Having just given birth, my advice would be to try and avoid another pregnancy for at least 2 years. This will ensure really strong glucose control and give your body the proper time to adjust and stabilize. Will you be using a contraception method during this time?
My husband and I would like to take some time before our next child. Waiting at least 2 years until our next pregnancy seems very reasonable for us. As far as contraception, we discussed different options and would like to learn more about diaphragm use. I heard about diaphragms through a friend, and it seems like it could be a good option for us. Can you tell me a little bit more about them?
First, let me start with an overview of what a diaphragm is. The contraceptive diaphragm is a shallow, dome-shaped latex or silicone device with a flexible rim that covers the cervix. This device, when inserted correctly, prevents pregnancy by putting a barrier between the sperm with the ovum. Additionally, the spermicide that is placed on the inside of the diaphragm provides a chemical barrier to pregnancy by destroying the sperm. The benefits of barrier methods are that they are safe, inexpensive options that have no inherent risks for women with diabetes. One of the most important aspects of proper diaphragm use is the fit. The diaphragm comes in different sizes, and it is important to have the medical professional who does your gynecological exams assess proper fit of the diaphragm in order to ensure efficacy of this contraceptive. Another significant aspect is the insertion of the diaphragm. It is important to note that unlike intrauterine devices, the diaphragm is not permanently indwelling. It must be reinserted no more than 6 hours before each time intercourse takes place, and then removed. Here is a pamphlet that you can reference which suggests positional techniques for inserting the device. You can practice each to find which one works best for you.
Okay, what else do I need to know?
Well, prior to insertion, you want to inspect the diaphragm for holes or punctures. You can do this by filling the diaphragm with water and checking for leaks. You must always use a spermicidal lubricant in order to be effective, as pregnancy cannot be prevented with just the diaphragm alone. Also, always empty your bladder before insertion. You want to properly wash and dry and store your diaphragm after each use, and you will dust it with cornstarch to preserve the diaphragm for storage, but be sure to rinse it off before you put it in again. Lola, can I ask you, do you know anything about toxic shock syndrome?
I think I've heard of it. I think I've seen it on my tampon box.
Yes, you probably have. TSS is a rare but potentially fatal complication that is caused by bacterial toxin. If you experience a sunburn-type rash, diarrhea, dizziness, faintness, weakness, sore throat, aching muscles and joints, sudden high fever, or vomiting, you'll want to call your practitioner right away. I hope this helps. And do you have any other questions for me concerning diaphragm use?
No, I think I'm good. Thank you so much for all your help.